Good evening, everyone. How are you all? So welcome again to First Aid AMC MCQ. This is Dr. Arshan, and you're having this class tonight as a free review session on questions of tips and tricks. All right. So I guess that you guys enjoyed our session in the last week, and we had our first review session on 23rd of January, right? And we discussed about psychiatry basics. I hope that you guys enjoyed it and also got the recording in our YouTube and also Facebook group. So tonight's session is mainly on some question solvation tips. You guys will get to know once you start your preparation that solving questions is one of the most important things for passing AMC MCQ. So if you keep two things side by side for your preparation, then in one side you keep your theory preparation, and in the other side you use your theory knowledge to solve these questions. Some people will misguide you in a sense that yes, you can just omit your theory, but just focus on some question solvation through some QBank or some other past solved file. So a lot of things are there in Facebook groups and courses. If you go into these kind of misguided lessons, a lot of candidates actually came back to us with a regret that yes, that was the misleading part that a lot of people are doing. You can't just focus on solving questions because AMC MCQ has a vast number of questions in their software. So you can't just say that, well, I will just solve some of the past questions and I'm going to pass this exam. That's never ever gonna happen. Yes, you might get related topics from the previous questions, but you need to know that particular topics from your theory knowledge. And once you have a very good idea about your theory, you can easily pick up what is the tips and what is the traps in the exam. In exam questions, always there is a little bit of clue to the diagnosis or clue to the answer. And there is also clue for falling into trap. And the examiners who made this question, they are very, very well experienced and they know how you think. And they just make the questions in a way you will think like, well, that is the question answer because this is how the examiners wanted you to think. But eventually you just fall into a trap by that examiner. So that's important to understand that what is the trap and what is the clue to that particular question. If you mix it up in the exam, then you are going to fail in that exam, most likely. And that's where your theory knowledge played a vital role to understand that particular traps. So never ever think that, well, I'm going to just subscribe to one of the QBank that has previous questions, and I will do it for 3 months, and then I'm going to appear the exam and pass the exam. No, that's never going to happen. Some lucky people, yes, like maybe 1 or 2, can get it. And don't get encouraged by that because you might not be that lucky person. That's 1 in 100. You need to think always that what is common and what is the worst case scenario that can happen in your exam. All right. So the importance of saying all these things is not to discourage you to solve questions, is to encourage you to solve questions depending on your theory knowledge. So that's the part where we will make you think properly. So in our course, you get to know all the theory that you need to solve the questions. And also, eventually, we have question solvation class every week. So 3 days a week, you get the class. 2 days, we work on your theory. And 1 day, we work on the question solvation. And eventually, we might just finish the theory earlier and then focus on the question mainly at the end of your course. And by that time, you will get to understand a lot much better way that what is that particular question is asking from you. All right, so let's start our question solvation class tonight, and I hope that you guys enjoyed it. Then, sorry, someone's microphone is on. We'll just mute everyone's microphone for the moment. And I can see some of you are in Facebook. So if you guys want to ask any questions, feel free to write it in the comment box so that I can have a look there and answer your question. And those of you who are in Zoom, you can obviously use the chat box to communicate with me for the moment. All right, so let's start. So that's your first question tonight. So this is a fluid balance question. A previously fit 52-year-old gentleman has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. 2 days after the operation, you note the following on his fluid balance sheet. Intravenous input is 2 liter. So you have given IV 2 liter, then nasogastric aspiration got 2 liter. Through the drain, you lost 700 ml. Through urine, 500 ml. When there is a fluid balance question in the exam, you need to first think about how much you have given to this patient. That means the total input and what is the total output. And based on that, you measure the fluid deficit of that patient, and then you maintain the fluid according to that particular deficit. You can see the biochemistry given. Most of them are normal, except the potassium is a little low. Which of the fluid balance regimens below would you do next 24-hour period? And that's 2 days after the operation. That means it's a third postoperative day. Now, these are your options. Don't look at the options at the moment. First of all, let us discuss about the fluid balance in a postoperative patient. In postoperative day 2 onward, we will follow this similar approach always. So any postoperative patient, our fluid balance will be like this. So you will get, every patient will have 2 liter normal saline plus 1 liter dextrose, plus they also will need some potassium also. So how you measure their potassium? Every liter of fluid that you are giving, so 20 milli equivalent of potassium per liter of fluid you are giving to this patient. We'll come to that later on. First of all, we need to find out how much input and output. So input we have got is 2 liter, right? Now find out the output. So if you measure the output, someone's video is on. Please do not open your video for the moment, guys. So then we find out the output of this patient. So if you look at here, the output nasogastric aspiration, that's the output. So 2 liter, drain 700 ml, urine output 500 ml. So you have got 2 plus 700 ml plus 500 ml. And that's a 2 liter, that means 2000 ml. Also, always with the output, we add 500 ml, and that's the insensible loss of fluid that you can't measure, especially from your skin, from your lungs, okay? Or sometimes the water that's coming with your stool. So that's called insensible water loss. So we always add this 500 ml with the output. So how much it comes? About 3.7 ml. So make it as a whole always. So that becomes 4 liter, right? Now, input is 2 liter, output 4 liter. So how much deficit this patient is having? 2 liter. So you need to give extra 2 liter to this patient as a maintenance fluid. Now, every patient in their postoperative day, they will get this is a like all the patient will get it because they are not eating at the moment. So you're just maintaining their fluid balance through this. With this, you have to add the deficit amount as well. Now that deficit amount will be measured or will be given by the normal saline. Sorry, this one, I'll just write it again. This one actually was a wrong formula, sorry for that. So usually the maintenance fluid will be 1 liter normal saline and 2 liter dextrose. Sorry for that. So 1 liter normal saline and 2 liter dextrose is always that's a maintenance fluid that we give. Now, if you look at here, there is 2 liter deficit amount in here. This 2 liter deficit or any deficit amount will always be given by the normal saline. So how much normal saline this patient will get? Already patient getting 1 liter, and now you will add another 2 liter. So now it will become 3 liter normal saline plus 2 liter dextrose. So how much fluid you are giving? 5 liter, right? So 3 plus 2, 5 liter. Now come to the potassium that you need to give. For potassium, every liter of fluid that you are giving, you have to multiply it by 20. So how much it will become then? 5 into 20 equal to 100. So 100 milli equivalent of potassium. So that's your whole fluid balance for the next 24 hours for this patient. Is this clear for everyone? Any question? So now if you come back to our original options, you just need to find out which option goes with your math. So look at here. So that option is your correct answer in here. 3 liter normal saline, 2 liter dextrose, and 100 milli equivalent of potassium chloride. Is this clear, guys? Anyone wants me to repeat? Please repeat. Okay. So always remember one thing, when you are doing the fluid balance for a patient in the postoperative day 2 onward, as a maintenance fluid, they will get 1 liter normal saline plus 2 liter dextrose plus 20 milli equivalent of potassium per liter of fluid that you are giving. Now that's for everyone, irrespective of their fluid deficit. Now, after that, you need to find out that how much input and how much is the output. In this patient, input is 2 liter through the IV line, and output you have measured as 4 liter. Now, this one actually came as a 3.7 liter, but we always make it as a full or a whole. That becomes easier for the exam. So this 3700 ml, we made it as a 4 liter, as a whole number. Now, 2 liter input, 4 liter output. So how much deficit? You are giving someone 2 liter, but patient is removing 4 liter from the body. So obviously 2 liter patient is deficient of. You need to give that 2 liter extra to this maintenance fluid that this patient is supposed to get. Now always remember, the deficit amount will be provided by the normal saline. So this patient already will get 1 liter normal saline, and he will need another 2 liter normal saline. So together it will become 3 liter normal saline, and others are normal. So 3 liter normal saline, 2 liter dextrose. Now 20 milliequivalent potassium per liter of fluid. That means in 1 liter fluid, you will give 20 milliequivalent potassium. So this patient is going to get 5-liter fluid. So 5-liter fluid equal to 5 into 20 equal to 100 milliequivalent of potassium. Okay, very easy if you can understand it. So 5 means, so this is 1 liter normal saline. You are adding another extra 2 liter. So how much it becomes? 3 liter normal saline plus 2 liter dextrose. So normal saline is a fluid, dextrose is a fluid. You're giving 3 liter and 2 liter fluid. That means 5 liter fluid. So very easy. I don't know like why you guys are having confusion, but it's very easy if you just basic math. If you just use that, then it becomes so easier. You just need to remember this formula. That's all, and then find out the input and output. Then the math will work by itself. Good. Anyone needs this thing to be repeat again? All good? Okay. Let's move on to the next question. So patient comes back from Thailand with a history of having sex with multiple prostitutes. After 1 week, patient presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, and sore throat. Atypical lymphocytes are also there. Monospot test came back negative. What is the diagnosis? So patient came back from Thailand. 1 week later, patient having these symptoms. And you have got HIV, Epstein-Barr virus, CMV, Hep A, and Ross River fever in your option. To understand this question, you need to have a good idea on the JM, this chart. So this chart is in your JM table 28.1. If you know this chart, you will understand this question pretty easily. Very important is to know how to differentiate between an EBV infection versus HIV infection, because it can be anything. And having sex with multiple prostitutes doesn't mean that it has to be HIV always. And that's the trap in here. The examiner knows that if a simple candidate who doesn't have too much idea about EBV, if they see that this line, they will immediately choose HIV as their option. And that's a trap. For someone who thinks that this is the correct answer, that might be the clue for them. But for you, that's a trap. Because the examiner exactly understands what you are thinking. You might be thinking, well, having sex with multiple prostitutes means it's HIV. But it's not. Always go through the whole question before reaching to a diagnosis. So if you look at here, the features in here are lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat. Now come to the EBV infection and HIV infection. Both of them can come as fever. Malaise is common because both of them are viral infection. Tonsillar hypertrophy and exudative pharyngitis. So it's very common that infectious mononucleosis or EBV infection, patient will always have sore throat. They will always have kind of mild pharyngeal erythema or pharyngitis. Even they can get some exudates in their tonsils or in their pharynx. But that will be very rare in HIV infection. Whereas mucocutaneous ulcer, like oral ulcer, is very common in HIV infection. Skin rash is common in HIV. Jaundice can be there in EBV. Cervical lymphadenopathy common in both. Hepatomegaly, splenomegaly common in EVV infection, but very rare in HIV. Atypical lymphocyte, common in EVV, also in HIV. Now, when you need to rule out HIV or EVV, you need to find out what is the main symptom for this patient. If a patient coming to you with cervical lymphadenopathy, exudative pharyngitis, or sore throat, and having splenomegaly, you would think about infectious mononucleosis as your diagnosis first. Whereas if a patient coming to you with fever, malaise, having cervical lymphadenopathy, mucocutaneous ulcer, diarrhea, then you think mainly about HIV infection. Okay, so splenomegaly, sore throat, these are not very common in HIV patient, rather it's very common in EVV infection. If you look at here, this patient mainly having lymphadenopathy, pharyngeal erythema, splenomegaly, and sore throat. Atypical lymphocyte can be there in both. Monospot. Now, if you know a little bit more about EVV, you will know that to diagnose Epstein-Barr virus infection, sometimes we do the monospot test. But monospot test negative, it doesn't mean that you can exclude infectious mononucleosis, because that's not a specific test for Epstein-Barr virus infection. Specific is if you do a Epstein-Barr virus serology and serology came back negative, then you can say this patient doesn't have EVV. But monospot test, heterophil antibody test, those tests are not highly specific to rule out Epstein-Barr virus infection. And this one is also another trap in your exam. Like if you maybe you already read JAM and somehow you came across monospot test, and you know that if monospot test negative, Epstein-Barr virus infection is also excluded. So you fall into the examiner's trap. So see that in one question, if you don't have a very good theory knowledge, it becomes really, really hard to understand or to get the appropriate answer. Without a lot of practice, without a lot of theory knowledge and question solvation, it becomes so hard for the exam to get to this answer. So that's why it's very important to understand the question, not to just have a look into one particular thing and just make up in your mind, no, this is the answer. So your logic should work in your exam. Otherwise, you will just fall under the trap of the examiner. Next, another similar travel-related question. A man coming back from Thailand after a short trip about a month ago, now coming to you with severe jaundice and fever. On exam, you find tender hepatomegaly, which is enlarged 5 centimeter. Investigation shows very high ALT, AST, GGT, and ALP. So all the hepatic enzymes are elevated. What is your most likely diagnosis? What do you think, guys? Active viral hepatitis A, Hep B, malaria, infectious mononucleosis, choledocholithiasis. So again, this will be a tricky case because most of you can always rule out that choledocholithiasis means it's a stone in the bile duct. So bile duct stone will not give you tender hepatomegaly, very unlikely. So you can rule that out. Then you have got infectious mononucleosis. It doesn't cause severe jaundice and it's not its primary symptom. As you remember from our previous discussion, rule that out. Now, malaria can cause jaundice, malaria can cause fever, okay? Same with the hep A and hep B. So these are the three options that you have got. So what you want to choose depends on the most common cause, always. Always in the exam, choose the commonest cause as well. Always. You can't think about something rare. Like all this A, B, C can be an option to choose, but you don't have that choice in the exam. You have to choose one. Now think a little bit more deeper. What causes tender hepatomegaly? That's the next question. If you look at here, hepatitis A, hepatitis B, they have this feature of anorexia, nausea, vomiting. They also get mild fever, and then they also get hepatomegaly. They get dark urine, pale stool. A lot of findings are there. The important thing when you come across the tender hepatomegaly in the exam, you think about this as your most likely cause. One is the viral hepatitis, then congestive cardiac failure, liver abscess, and enteric fever or typhoid. These are the four causes which will lead you to have this tender hepatomegaly. Now, malaria can cause jaundice, but most of the time you will not get severe hepatomegaly in acute malaria. Chronic malaria patient can get hepatomegaly, splenomegaly, that's common. But this is an acute symptom. Just in 1 month, patient has got this symptom. Acute malaria usually will not give you severely enlarged liver or splenomegaly. So rule that out in terms of acute malaria. So that you need to know that, otherwise you will never ever be able to rule out malaria from this stem. So always remember, in case of acute malaria, you will not get hepatomegaly, which is tender. Chronic malaria patient gets hepatomegaly, splenomegaly is more common for them. Now, between A and B, you should think about hepatitis when you get a tender hepatomegaly with fever, jaundice, and very high ALT, AST. That's important. If you get AST, ALT very high in a patient, having a history of traveling to an endemic area, and also tender hepatomegaly, you immediately think about hepatitis first. Now, depending on your stem, you could choose Hep B or Hep A. Sometimes if they want you to choose Hep B, they will say that patient had multiple sexual intercourse or multiple unprotected sexual intercourse during the travel. Or patient went to a party and then used some IV needles. If those are the clue given in your question, then you will think about viral hepatitis B. Otherwise, more common for someone went to an endemic area is viral hepatitis A. Because that's more common rather than hepatitis B. And also the transmission rate is very high. And also the hepatitis A, the incubation period is mainly 15 to 45 days. So this patient came 1 month ago, which falls under this incubation period. So all of it goes with the hepatitis A actually, but look for some clue for hepatitis B also. So you need to be very careful in the exam. Sometimes they just add some new things in the stem and the answer totally changes. Sometimes they delete a specific thing from the stem, answer totally changes. And those people who memorize answer or just read some of the QBank subscription and went for exam, they will fall into that trap. Yes, obviously, because that's the incubation period, Dr. Sidra, for hepatitis A. And you can see in here that when you get a patient with jaundice, you know that jaundice can be mainly 3 types: hepatocellular jaundice, or that's mainly viral hepatitis. Then you have got hemolytic and obstructive. If alkaline phosphatase is mainly increased, then you mainly think about obstructive jaundice. If your ALT and AST increase, then you think about viral hepatitis or hepatocellular hepatitis. If GGT increased, GGT is mainly increased in patient with alcoholic hepatitis or alcoholic cirrhosis. Otherwise, it doesn't get increased. Okay, so these values will also help you in the exam. Move on to the next question. Scenario of a patient with a fall from the bicycle about a week ago, and then the patient got a helmet fracture. No confusion, no amnesia, but patient has headache which increase with coughing. Headache which increase with the coughing, do you know what does it mean? After a head injury, if a patient complains headache and that increase with coughing, do you know what that means? Yes, very good, Dr. Sidra. So yes, it means that patient might have raised intracranial pressure and very high chance that this patient might got intracerebral injury. Now, you have got to understand that what is the most likely diagnosis for this patient. Is it intracerebral hemorrhage, subarachnoid hemorrhage, extradural or epidural hemorrhage, subdural hemorrhage, or just a concussion? We would not think about concussion when patient having features of raised ICP. Subarachnoid hemorrhage after a fall from the bicycle is not very common. Common is A, C, and D. Now, always remember, if this is a case of intracranial hemorrhage, patient will have features of neurological deficit. What are those? Like patient can have weakness in anywhere else, weakness in one part of the body. So that features of a stroke will be there. This patient doesn't have any hemiplegia, no one-sided weakness, nothing like that. So we don't just think about this in here. But it can be a possibility, but the question is most likely diagnosis. What is your most likely diagnosis? Who had a fall from a bicycle 1 week ago. Now, if it is an ICS, patient would not have any features of neurological deficit in 1 week. So if it was actually a case of hemorrhage inside the brain, in 1 week time, this patient might even die. Okay, so something less than intracranial hemorrhage is a more possibility. So is it an extradural or subdural? That's the question. Always remember, when a patient on a bicycle and had a helmet fracture, helmet is really, really hard. Patient with fall from bicycle usually doesn't get helmet fracture unless it is really a big hit. So extradural hemorrhage versus subdural hemorrhage, if you need to differentiate between these two based on just a history, you need to think that if there is features of any lucid interval or not, which is more common in EDH or epidural hemorrhage. Another thing is that to get subdural hemorrhage, patient needs more high impact. And only with a helmet fracture, a patient has a chance that they can get a high impact force during that accident. Now, most likely when a patient after 1 week time coming to you with headache after a fall had a helmet fracture, you would rather think about SDS rather than EDH. So epidural hematoma or epidural hematoma, it's a scalp fracture from a blunt trauma which will cause laceration of the arterial vessels. And fracture mainly occur at the region of the temporal bone. In contrast to subdural hematomas, a tremendous force is usually required. So for subdural hematoma, usually you will need more force. Another important thing is epidural hematoma has a triphasic presentation. So that's called lucid interval. Patient usually experience a brief loss of consciousness followed by a lucid interval, which lasts for minutes to hours. That means in that lucid interval, patient will look completely fine. And then again, patient will develop headache, progressive confusion, and hemiparesis. So that three-phase presentation or triphasic presentation is very common in epidural hematoma. And that's how it looks like. Okay, see the biconvex shape, and that's what you get in these patients. In subdural hematoma, if you do a CT scan, you will get a crescent-shaped shadow like this. Okay, so if it is biconvex, that's epidural. If it is crescent shape, that's subdural. And subdural hematoma is mainly rupture of the bridging veins. Their presentation is mainly like it's asymptomatic presentation, like patient might get only headache, sometimes mental status alteration. One of the important thing is that epidural hematoma patient presents acutely, but subdural patient sometimes even can present to you 1 month later or 1 month after their trauma. So this patient also came to you after a week. Epidural hematoma patient will present more earlier. Okay. So based on all of it, it's a good idea to choose subdural hematoma in this question. If this patient came to you like fall from a bicycle yesterday, if that was the case, you could think about extradural hematoma or epidural hematoma. Now let's go into genetics a little bit. Tonight we are going to discuss a little bit of basics about genetics. Genetics is very important and high yielding for the exam. And you guys should know that in exam, you get these questions. Some of them are marked 2, some of them 4, 6, 8, 10. Based on the difficulty level, the mark is different. And you don't know which one's mark is high and which one is low. You just need to treat every question equally. But if you see a genetics related question, think that this is a high mark question. Okay. Now you need to know the basic of genetics to get to understand those questions. Otherwise, you will get confused in many ways. So the question in here is, parents came to you that their son has hereditary spherocytosis. And they want to know that what is the chance that their siblings will get the same disease. Okay, so parents came to you that their son has hereditary spherocytosis. So they are coming to you to know that what is the chance that his siblings will get the same disease. Now, to know this genetic hereditary inheritance, you first need to know that what is the mode of transmission for hereditary spherocytosis. If you only know that, then you can answer this correctly. So that's one of the other things to remember. Like you need to first just go through the common causes of autosomal dominant, autosomal recessive, and X-linked recessive mode of inheritance. So these are the 3 mode of inheritance which comes in exam. So one of them are autosomal dominant, autosomal recessive, and X-linked recessive. First, let's discuss about autosomal dominant. Now, for the purpose of today's discussion, we will keep father as XY. Don't think that this XY as a sex-linked chromosome. Think it that this is just a somatic chromosome or autosomal chromosome. And that's the mother, XX. We can also use like AB, okay, and AA. That becomes more relevant when you use like this. But just for the purpose of your understanding, we will keep it as XY and XX. XX is the female, and that's the male. Now, let's say we are discussing about autosomal dominant inheritance. So what happens? So there is a 4 genetic possibility for this thing. So you have got, now before we go into detail of that, let's say that we are talking about autosomal dominant. Autosomal dominant are usually, they need only one gene to be defective. Let's say that this Y gene is carrying the defective gene. And that's all that it needed to transmit the disease fully. And all other genes are fine. So there are 4 possibilities. So this X and X, and then this X and another X. And then let's talk about Y. X and Y prime. And then again X and Y prime. Now have a look in here. If you look in here, that this child is normal, this child is normal, this child carrying one defective gene, and that is enough for this child to have the full disease. So that's the diseased child, and this one is also same, that's the diseased child. So always remember, autosomal dominant does not depend that if the son or daughter will be affected. Both son and daughter can have equal chance of getting the disease. Unlike your X-linked chromosome or X-linked recessive disease, where son usually get the disease and daughter are carrier. But in autosomal diseases, always remember that both son and daughter have equal chance to get the disease. Now in here, how much percentage are normal? So 50% are normal and 50% are diseased. So when a father, or let's say when one partner have a autosomal dominant disease and they marry another normal person, their son and daughter have 50% chance that they can become normal and 50% chance that they can become diseased. And that happens in each pregnancy. So if we go back to this question, what will be your answer? So hereditary spherocytosis is autosomal dominant. So what do you think your answer will be? Yeah, so 50% of his brothers and sisters has a chance that they can get the disease. Don't think in that way that, well, one son has already got the disease, so another only 25% is present. No, it's not like that. In every pregnancy, there is a 50% chance to get the disease. Okay, so now you understand about autosomal dominant. Let's talk about autosomal recessive a little bit. Now, in case of autosomal recessive, you need 2 defective genes to get the full-blown disease. So that's the only difference between the dominant and recessive gene. So to get an autosomal recessive mode of inheritance, or to get the full-blown disease from an autosomal recessive inheritance, you need 2 defective genes. If you get only one, you become a carrier, not a diseased person. Now let's say one thalassemia father, like a thalassemia minor father, married another thalassemia minor mother. So one partner has got one defective gene and another partner also got one defective gene. So both of them are carrier of thalassemia. Very commonly asked question, this one. Now what will happen? So this X and this X becomes one child. Then this X and X prime. And then you have got Y and X prime. And Y and X. Now look at this thing. So what do you think that what is the possibility or what is the chance to get a thalassemia measure in this mode of inheritance? Yeah, 25%. So this X prime, they have two defective gene, right? That means this child will have chance to get full-blown disease or thalassemia measure. Now this one and this one, this 50% will be carrier and this 25% will be normal or healthy. So that's your answer to your autosomal recessive condition. Things will change if only one partner is the carrier. So now you can easily find it out. So whatever question comes in the exam, you just use this formula and find out the percentage. All right, guys, any questions so far? All right. Now let me show you one thing. Let's see what you think about it. Now, let's say that this is a X-linked recessive pattern. Okay. In X-linked recessive pattern, this XY has a meaning. XY actually means in here that they are the male chromosome and XS is the female chromosome. Now, let's say this father had a X-linked recessive condition and married to a normal person. And these are the possibilities that happened. What will be the possibilities? Always remember, to become a X-linked recessive condition or full-blown disease, you need mainly two same gene or two same sex gene to be affected. Now in here you can see that only one XX, these are same gene, but only one is affected. Same with this one, only one is affected. So these are actually they will be called as female child. So these two female, they will be the carrier and the sons will be normal. Okay. Now let's say a little bit more interesting. what do you think the possibility of disease in the son? Or what do you think about this combination? This is an X-linked recessive condition. Okay, you have to say that percentage of disease, or what is the percentage in son and what is the percentage in daughter. So let's talk about it. So that's when it becomes tricky. For female, because they have two same gene, XX, one normal will counteract the other abnormal, and they will not get the full-blown disease. They will get carrier. This one, same, they are carrier. So both of the daughter will be carrier. That's right, Dr. Sidra, 100% daughter is carrier. In this case, or we can say 50% of children is carrier. Now, the son is the main issue, because in here, if you see that the son has two different chromosomes, one is X, another Y. They can't counteract each other. And for son, even one abnormal gene is enough to cause the disease. So this will be a diseased, this will be a diseased son. So that's the confusion in X-linked recessive. Okay, you will get confused if you don't remember this part, that in X-linked recessive, for female, they need two genes. Otherwise, one normal can counteract this one and they will remain unaffected or just a carrier. But son doesn't have two X, they have one X, another Y. So if one X is defective, this Y cannot counteract this X. So they will be the diseased population in here. So always remember, in X-linked recessive, mother gives diseased to the child, to the son. Okay, so if mother is diseased, they will give the disease to the son. Okay, so I hope that you guys understood it. I know that a lot of you has problem with this one particularly. So I hope that this is now you are better with this. So a lot of things are written in here. You can just give it a read. All the percentage of autosomal recessive and dominant. Play with this, okay? Because just think that what can happen if one father is affected and mother is carrier. So play with this knowledge and try to find out the answer. So that's how you learn genetics. Very interesting if you understand it. Next question, 50 years old man comes to you with weakness of lower limbs. She drugs, okay, it should be he. So he drugs his foot while walking. Dorsiflexion and plantar flexion is weak. Reflex are exaggerated. Equivocal plantar response. What is your diagnosis? So it's a 40-year-old man coming with weakness of lower limbs. That means both lower limb is having weakness. He drugs his foot while walking. having dorsiflexion and plantar flexion weak. So muscle weakness we can see, but the reflex has been exaggerated. And having an equivocal plantar response. Is it cervical spine MS, motor neuron disease, spinal canal stenosis, or lesion in the cerebral cortex? They are asking you what is the diagnosis. Always remember, if you get a patient, especially 40, 50-year-old man, having both upper motor neuron and lower motor neuron type of signs in their limbs or in their one particular leg, that's MND. Okay, so always remember that, because the mixed pattern of MND is the most common one, where you get both upper motor neuron and lower motor neuron type of signs. In this patient, you have got weakness of the lower limb and dragging the foot. That's a mainly lower motor neuron type of feature, whereas reflex has been exaggerated. That's upper motor neuron type of feature. Another is equivocal plantar response. Equivocal or absent plantar response is mainly lower motor neuron type of feature. If it was extensor, then we would think about upper motor. Now you got that in here, both upper motor and lower motor neuron type of palsy features are here. When you get something like that, you immediately think about motor neuron disease. Why not others? Now talking about the MS usually gives you always the upper motor neuron type of feature. And if it is cervical spine MS, patient should have features in their hand also. But this patient doesn't have any feature in the upper limb. So very unlikely that it's a cervical spine MS. Then a spinal canal stenosis also gives you upper motor neuron type of feature. And in that case, you will get reflex exaggerated. The plantar response will be extensor, spastic paraplegia, hypertonia. So those are the features that you will look for in a spinal canal stenosis. And most importantly, if it's a lower limb feature, patient with a spinal canal stenosis will have low back pain most of the time. And lesion in the cerebral cortex, that's not a diagnosis, so don't think about it. All right, so even with exclusion, you can come to your diagnosis. If you don't know your diagnosis, you try to exclude other option. And this is your upper motor neuron and lower motor neuron type of feature. So you can see that patient with upper motor neuron, they get spasticity, whereas lower motor neuron, they get hypotonia or flaccid paralysis. They get hyperreflexia, lower motor get hyporeflexia. Okay, and also they get hypertonia, they get hypotonia. Now the same question, they are asking different question, like their question is different, but the stem is same. 58-year-old man dragging left foot, reflex on the left lower limb has got increased, plantar flexion, dorsiflexion is weak ankle movement, equivocal plantar reflex, upper limb and face are normal. What is the lesion site? So site of the lesion they are asking, you have to look at the question very carefully. Always try to find out what actually they are asking. It's not about only getting the diagnosis correct. It mainly, you need to first think that what they're actually asking from you. So common peroneal nerve, cervical spinal cord, L5S1 nerve root, cerebral cortex, brainstem. Let's try to exclude one by one. Common peroneal nerve is a nerve that supplies your lower leg and helps with dorsiflexion and eversion of your foot. Always remember one thing, any peripheral nerve, they don't cause any problem with the reflex. If reflex has been equivocal, decreased, increased, if reflex is involved, that's not a peripheral nerve problem. So common peroneal nerve is the peripheral nerve. That means the extremities nerve. You immediately rule that out. And also it does not cause any problem with the plantar flexion. Same cervical spinal cord, patient upper limb should not be normal in that case. L5-S1 nerve root. L5-S1 nerve root, they usually give you sciatica-like feature. They will never ever cause exaggerated reflex. They will not cause trouble with any reflex also, because L5 usually does not have any reflex. Okay? If you get like reflex on the lower limb increased, you rule out L5, you rule out any other peripheral nerve. Now, D and E, brainstem. If there is brainstem problem, you will get brainstem features. What brainstem features are? So you will get dysphagia, so trouble with swallowing, trouble with speech, trouble with voice, so hoarseness of voice, diplopia, nystagmus. So all those features will be brainstem features. So you haven't got any features of something like that in here. Even by exclusion, your correct option is D, which is cerebral cortex. And if you think about the diagnosis, this is a motor neuron disease. And what is motor neuron disease? It's the degeneration of motor neurons in your brain and in your cerebral cortex. Okay, not only cerebral cortex, actually, all the motor neurons in your body will be affected in MND. Okay, now, if you look at here, that's your option to choose. The name says that motor neuron disease. That means all the motor neurons in your cerebral cortex, brainstem, everywhere in your, or in the spinal cord, everywhere there are motor neurons, that motor neurons will be affected. No problem with the sensation in here. Now you might be thinking that if this patient's cerebral cortex has got affected, how come this patient getting symptoms or signs in their lower limb? This is how. This is called homunculus. In your brain, you have got these two cerebral hemispheres. And what are these things? These are the part of your brain involved with the motor function. So this part of your brain helps with the facial movement. This part, hand movement. This part is the body. This one is the leg. Now, if this motor neurons in this part of the cerebral cortex has got the degeneration, you will get symptoms only in the lower limbs. Okay, so that's why you are getting it only here, not anywhere else. And eventually this will get progressive. Clear, guys? Any questions so far? I know that for you guys, this can be a little bit of complex things because many of you are you just started your preparation. But through question solvation, you get to know this theory as well, right? So that this helps you eventually. And initially, you will have trouble to understand it. And that's common for everyone. So don't get stressed about it. Once you know how AMC makes their question, once you start knowing the theory much better way, you have finished your handbook, this will become easier day by day. Next, a 64-year-old smoker woman with blood pressure 135/65, cholesterol HDL ratio 6.6 to 1, CVD chart is given, and they're asking what is her 5-yearly CVD risk. Very, very important. So this 5-yearly absolute CVD risk assessment chart comes in exam very commonly. And when you get this kind of question, you always think that these are high mark questions in the exam. So you get this kind of graph in the exam, and you need to find out the 5-yearly CVD risk from this chart. Now you can see various colors in here. What's that? What does it mean? The color shows the risk of a patient. So you need to find out your patient, where exactly your patient falls. Now you know that this is a woman, so you just look at this part, forget about men chart. Then you can find out one is a smoker, another non-smoker. So your patient is a smoker and it's a 64-year-old. So smoker is this part and 64 means this range. So you are mainly looking into this box. Now that you know which box you are looking, then you can see that on the y-axis, that's your systolic blood pressure. And in the x-axis, that's your total cholesterol HDL ratio. So you need to know this measurement. Now, what is the systolic blood pressure for your patient? 135. So where 135 will fall, that's an important thing. You can see 120, 140, 160, 179. Same in here also. Now, always remember, if we think about this particular box, tell me what is the maximum systolic blood pressure you can put in this box. Very good, Dr. Aid. Yes, 130. 130 is the maximum you can put. Same with here. It's not 140, it's 150 is the maximum number you can put here. This one is 170. So this is how. Now let's say you have got a number exactly at the margin, 130. If you get something in the margin, you choose the next one. So if this patient is having 130 systolic blood pressure, you will choose this one. Okay, so marginal, always we choose the next one. That's one of the tricky things that comes in exam. Always they give value at the margin. And if they give marginal number, always choose the next one. So this part you know. So our patient's systolic blood pressure is 135. So which box this patient will fall? Second box. So we are mainly thinking about second box in here. Now look at the cholesterol and HDL ratio. So ratio is 6.6. You just look into 6.6. This one is not very important. Now you can see in here 4, 5, 6, 7, 8. Now again, for this chart, for this box, what is the maximum value you can put in this box? Now you can put like 4, 5, 6, 7, 8. Yes, Dr. Karishma, Dr. Umayama, very, very good. Yes, you can put maximum is 4.5. Same in here, 5.5, 6.5, 7.5, 8.5. Okay. Same with the marginal. If 4.5, you choose the next box. Now our patient has got 6.6. So which box this patient will fall? 1, 2, 3, 4, 5. So 6.6, where do you think this patient will fall? In the 3 or 4? fourth box, right? This box. Now you already you know how to do the graph. So you go up, up, up. And so this yellow box is your patient's box, right? Now, what you need to do from this yellow box, you need to find out what yellow box risk is. That will be given in your exam. Let's have a look, see that if this. So this is an Australian cardiovascular risk chart, and there's an Australian guideline. See that this is what they will give it to you in the exam. Now you know that your patient is having this yellow, right? Let's have a look again, see that if that's the right yellow. Yeah, so that's the right yellow. So you have got your patient answer will be between 16 to 19% risk of having a cardiovascular complication in the next 5 years. Okay, and always remember, if someone's systolic blood pressure is more than 180 or their total cholesterol is more than 7.5, they are already a high risk of CVD. That means you immediately put them into more than 30%. You don't need to use this chart. Okay, so more than 180 blood pressure, systolic, and total cholesterol more than 7.5, they are already increased CVD risk factor. All right, guys, any problem with this CVD risk assessment? Okay, now what I would like to do, let's take a 5-minute break, and then we will discuss some nerve-related complications, some of the neuropathies which comes in the exam so frequently. And if you can understand these questions properly, you will end up getting a very good score in the exam. So we'll discuss radial nerve injury. We'll discuss common peroneal nerve injury after the break. Okay, so let's take a 5-minute break then. All right, everyone. So let's start again. So this is your question of radial nerve injury. Or we can think about any nerve injury in your hand. So if you look at this question, this is the patient coming to you who had sustained a stab wound to the back of the left forearm. So let's say this area in a pub brawl. He is trying to straighten his fingers on his command. And if you see that this hand in the right side, patient is able to do full extension of the wrist and fingers. In this arm, extension of the wrist is okay, but the patient cannot do extension of the fingers. And they're asking which one of the following nerve is the most likely to have been injured. All right, so you need to understand by looking at the picture what they are trying to say. And you've got all the options. If you don't understand the functions of each of the nerves of the hand, you will never ever get to understand this question. That means you need to know what is the function of median nerve, what is the function of ulnar nerve, and what is the function of radial nerve. These are the three peripheral nerves of your upper arm or upper limb. And this posterior and anterior interosseous nerve, these are some branches of these nerves. We'll discuss that. Now, always remember, so this part, so the dorsum of your hand, that is mainly supplied by the radial nerve. And if you talk about this side or your palmar aspect of your hand, this side is mainly supplied by ulnar nerve and median nerve. Now, if you get a problem with this part, this side, or you can say the dorsal aspect of the hand, think about radial nerve immediately. And also, always remember this one, that median nerve, ulnar nerve mainly helps with flexion of your wrist and fingers, whereas radial nerve helps with extension of the wrist and fingers. So having this background knowledge will help you to exclude some of the option immediately. So this patient mainly having problem with extension of the extension of the finger. So if extension of finger is mainly hampered, that means maybe the radial nerve is injured. But what if they are asking you something more specific than that? Okay, you can immediately rule out median nerve and ulnar nerve based on what you already know. And then you go for radial nerve, posterior interosseous nerve, and anterior interosseous nerve. Let's discuss it. This is the radial nerve anatomy. If you look at here, that's your clavicle, that's the scapula, and this is your humerus, and that's the elbow joint. Then you have got your radius and ulnar bone. This is the wrist joint, and that's your hand. The radial nerve start from here. Okay. Turn backward through the surgical or spiral groove of humerus from here. And then again turn in the front around the elbow joint, and it divides into two branches. One branch is called posterior interosseous nerve. Another branch is called superficial radial nerve. Okay, so that's the radial nerve anatomy. You need to know it to understand what we are going to discuss next. Now, this radial nerve can be injured anywhere in its path or journey, right? So it can be injured in the axilla. It can be injured in the humerus shaft fracture. It can be injured in the elbow dislocation or fracture around here. So it can be injured anywhere. And the findings will be different based on where the radial nerve has got injured. Now, let's say radial nerve has got injured at the axilla. What will happen? In case of axillary injury, that means the whole radial nerve will be injured. Radial nerve gives both motor and sensory supply to your arm. So you will get loss of extension of the forearm, weakness of supination, Loss of extension of the hand and finger, that means wrist and finger. That means all extension will be gone. So extension of your forearm, extension of your wrist, extension of your fingers, everything will be gone. That means this patient will get wrist drop, finger drop. And what is the sensation of radial nerve? Radial nerve supplies to the dorsum of your hand. And if you look at here, it supplies to your thumb, index finger, and half of the middle finger. Okay, so actually this part will be supplied by the radial nerve. So in case of radial nerve injury, there will be loss of sensation in this area. So thumb, index finger, middle finger. So that's your injury of the radial nerve in the axillary region. What about if someone got a mid shaft of the humerus injury or fracture? Like this part has got fracture. So what can happen? Radial nerve can be injured in here also. So what will be the finding? Finding will be more or less similar, just like the axillary one. Only difference is in sensory loss. So motor deficit will be same. Here, there will be loss of sensation in the radial 3.5 digit. That means the finger loss of sensation will be there, but there will be no loss of sensation in the posterior forearm or arm. Now, one of the things that you need to understand, if someone got injury to the axillary area, they will also lose sensation of their arm and forearm, apart from this area of the fingers. But if someone has got injury at the mid-arm, then there will be no loss of sensation in the posterior forearm or arm. Only loss of sensation will be on the hand. So that's the only difference. Let's go down to elbow. So if patient got injury just below the elbow, if just below the elbow patient gets injury, they usually get injury to the posterior interosseous nerve. And always remember, posterior interosseous nerve is only a motor nerve. It does not give any sensation. So there will be no sensory deficit. Only thing that you will get is the loss of extension of fingers. So you will get only finger loss of extension or a finger drop. That's the only function of this nerve. Okay. So that's just below the elbow. What about injury at the distal forearm? Stabbing or laceration of forearm result in injury to the superficial branch of the radial nerve. If it is the superficial branch of the radial nerve injury, always remember the superficial branch of radial nerve is entirely a sensory nerve. There will be only loss of sensation in your 3.5 fingers. There will be no loss of motor function. Now, looking at the picture, what do you think this patient has got? Most likely the injury was more proximal, maybe in this area, not in this area. If the patient is mainly having loss of finger extension, they haven't talked about any sensory problem. So what do you think? Your answer can be radial nerve. Your answer can be posterior interosseous nerve. But which one is more better? Obviously, the posterior interosseous nerve. Because if radial nerve, if you choose, it means that everything supplied by radial nerve should be lost. But in this question, only thing that is lost is the finger extension. And that is exactly the function of posterior interosseous nerve. Why not anterior? Because this is a branch of median nerve. So median nerve we are not thinking at the moment. So this one is also out. So that's your correct answer. Okay, clear guys? So if a patient get both dropping of the wrist and dropping of the finger, the injury should be more proximal, most likely in the mid-arm or axillary region. Okay, because below elbow, then most likely that there will be loss of extension of the finger only. That means only finger drop. Is this clear for everyone? Anything that you want to ask? This is a very, very high yielding discussion. If you can remember these things, it will save a lot of time in your preparation. Okay, now that we know the radial nerve injury or radial nerve function, now let's move on to the lower limb nerve injury, another high yield topic. A 64-year-old woman complains of dragging her right foot and numbness and paresthesia in that leg. So dragging of the right foot. On exam, there is foot drop with weakness of the dorsiflexion, inversion, and eversion of the ankle. The reflexes are normal. There is loss of appreciation, that means loss of sensation of pinprick on the outer side of the lower leg. A lesion of which of the following nerve root is most likely the cause of her presentation? Another important thing, so let's discuss it, then we will come back to these options. If we want to know better way about the lower limb nerves, always start with the first. So in your lumbosacral plexus, sciatic nerve will be emerged from L2, L3, L4, L5, S1 nerve root. So all this nerve root will eventually give you the sciatic nerve. And the sciatic nerve will come from the back of your thigh. And then when it comes around this knee joint, it divides into two branches. One branch is common peroneal nerve, another branch is tibial nerve. Common peroneal nerves twist around the head of the fibula to the front of your knee joint and then supplies to the anterior part of your leg, just like this. And tibial nerve goes to the back of your thigh, back of your calf, and the back of your leg. Okay? And then common peroneal nerves come in front and it divides into two nerves. One is superficial peroneal nerve, another is deep peroneal nerve. If you look at here, this is the common peroneal nerve dividing into superficial peroneal and deep peroneal nerve. Okay. Now, let's move into one by one the function of these nerves. Common peroneal nerve, let's start with sensory function first. It gives sensation to the whole anterior portion of your leg. Now, if we come into the deep and superficial peroneal nerve, superficial peroneal nerve will supply the whole anterior leg and also the dorsum of your foot. Only this part, which is the interdigital space between first and second toe, this space is supplied by the deep peroneal nerve, and all other this part will be supplied by the superficial peroneal nerve. So that's the sensory function. Now come to the motor function. Common peroneal nerve, the supply it or the motor function it gives, you can remember by emergency department, ED. E for eversion of the ankle and D for dorsiflexion of the ankle. I hope you understand what is eversion and dorsiflexion. Now, Branch of common peroneal nerve, one is deep peroneal nerve, another is superficial peroneal nerve. This D for deep peroneal nerve will give you dorsiflexion. D for D. Okay, very easy to remember. And other one will be given by the superficial peroneal nerve. All right, now you know the function of this common peroneal nerve. And the tibial nerve, because it goes to the back of your calf or back of your leg, tibial nerve will give supply to the plantar flexion of the foot. So plantar flexion will be done by the tibial nerve. And sciatic nerve actually will give everything, every function of your lower limb will be done by the sciatic nerve. Superficial peroneal nerve, you already know what's the function of it. L5 nerve root and L4 nerve root. If you think about the dermatome of lower limb, this is the inner part of your leg. The inner part of your leg is supplied by L4 and the outer part is supplied by L5. Okay. Same with this, the L5 will also supply this whole outer part. And S1 will supply this part and also the sole. As you remember, L5 will never ever cause any problem with the reflex because it does not give any reflex. Whereas other nerve root like L3, L4 gives knee jerk, whereas S1, S2 gives ankle jerk. So L3 gives knee jerk, L5 does not give any reflex, and then you have S1, S2 which gives ankle jerk. And L5 helps with all of these dorsiflexion, inversion, eversion. It does not give you plantar flexion, but it gives you all other function of the ankle. So dorsiflexion, inversion, eversion given by L5. Now, having this discussion, guys, what do you think that this patient has got? B, right? L5 nerve root, because L5 nerve root, patient having weakness of dorsiflexion, inversion, eversion. So that supplies by L5. Reflex are normal, so L5 does not give any reflex. And if you see the loss of sensation, that's also on the outer side of the lower leg. That's the dermatome of L5. So that's your answer, L5 nerve root. Why not superficial peroneal nerve? Because if it is superficial peroneal nerve, the only function it has is eversion, right? But this patient having dorsiflexion, inversion, eversion, all gone. Clear, Dr. Thaisia? Good. All right. So do you guys understand it? Any question with the lower limb nerve root? And foot drop, why patient gets foot drop, Dr. Shamila? Foot drop means you can't raise your ankle up. And raising your ankle up is the dorsiflexion. So if patient having L5 nerve root problem, they can't do dorsiflexion, so they will eventually get foot drop. Okay. So any nerve which causes trouble with dorsiflexion, that can give you foot drop. So foot drop can be done by L5 nerve root. Foot drop can be done by this deep peroneal nerve or common peroneal nerve. So foot drop only will not give you the answer. Great. So you guys understand what I'm talking about, right? Very good. Next, another important topic is pneumothorax. It's a very, very commonly asked question in the exam. So all of you know that what is pneumothorax? Pneumothorax means that patient having accumulation of air in their pleural cavity. And because of accumulated air in the pleural cavity, it causes compression over the lung tissue, and patient starts to feel difficulty in breathing, chest pain, and eventually they also develop hypoxia and loss of or decreased oxygen saturation. Now that's the pneumothorax, but pneumothorax is much more detailed than that. When we talk about pneumothorax, first thing that we know that what is the type of pneumothorax? So if you want to know about type of pneumothorax has especially two types. One is primary spontaneous pneumothorax, which means that pneumothorax happening spontaneously without any underlying condition. So this patient does not have any underlying lung condition, nothing, it just happened. Another is secondary pneumothorax, which means that patient has some underlying lung condition and that has caused pneumothorax in this patient, like patient having severe asthma, COPD, bronchiectasis, emphysema. So any lung condition can cause pneumothorax, and if that is the cause, that's secondary pneumothorax. Or someone got a trauma, motor vehicle accident, then they got a pneumothorax, that's also secondary pneumothorax. Now that you know that what is primary and secondary, how we treat those patients. We are not talking about tension pneumothorax for now. All right, so just think about primary and secondary pneumothorax at the moment. In case of primary pneumothorax, first thing that you look into the question is that, is this patient having severe symptoms? That's the first thing. Patient having significant symptoms, you don't think anything, you just go for catheter or needle aspiration immediately. So significant symptoms, you don't need small or large pneumothorax for that. Patient having significant shortness of breath, chest pain, saturation going down, that's a significant symptom. Even if it's a very small pneumothorax, you go for catheter aspiration. Now, previously we would do aspiration only in tension pneumothorax, but that criteria has been gone. We no longer just do that. Nowadays, usually catheter aspiration is the first thing that we do. And if needed, then we go for chest drain. So that's a significant symptom. Now that let's say patient does not have symptom or having just a very minimal symptom, then you look for the size. Is it a small or large pneumothorax? A small pneumothorax, in the stem, they will say that it's less than 15% in size or less than 2 centimeter rim of air that you can see in the chest X-ray. You don't need to measure it, they will give it to you in the stem. So if it's less than 15% or less than 2 centimeter, whatever they give it to you, and patient having minimal symptom, you don't need to do anything, you just observe the patient. Okay, so keep the patient admitted, do serial chest X-ray if needed, but you don't need to do anything. What if it's large? Large means more than 15% or more than 2 centimeter rim of air. If it's large, but still patient does not have that much symptoms, then two options are possible. One, you can just observe the patient. If an option of giving oxygen is there, then you can choose it because giving oxygen will help to reabsorb the excess fluid that has been accumulated in the pleural cavity. Now, that's also important to understand. If patient oxygen saturation is more than 95%, you don't need to give oxygen for that. But if less than 95%, then giving oxygen is a good idea. And that's according to your handbook, that giving oxygen to a pneumothorax patient will help to reabsorb the excess accumulated pleural air. No, giving oxygen will not make it worse. If you give a positive pressure ventilation, that can cause increase of the pneumothorax. But giving oxygen, you are not giving a positive pressure. It's a normal flow of oxygen you are giving. So you will not cause any worsening of pneumothorax. All right. Now, that's your pneumothorax management. Comes in exam in so many ways. Now, let's say you have given catheter aspiration in this patient, but it's still no improvement. Then the next option is chest drain. Okay. Another indication of having a chest drain is that you did catheter aspiration, but when you did, more than 3 liter air aspirated at the same time, or you did a repeat chest X-ray after 2 to 4 hours, and it's showing more than 15% pneumothorax or significant symptoms is still going on. So let's say you did a catheter aspiration, and then after 4 hours, you did a repeat X-ray to see how much it has been improved. But you have found that it's still more than 15% pneumothorax or patient having significant symptoms. That is an indication to give chest drain to this patient. So after that, let's come into the secondary pneumothorax. Secondary pneumothorax, you already know what will fall under here. So any previous lung condition or any chest trauma. Then you look for if this patient having significant symptoms, or if the patient's age more than 50, or rim of air more than 2 centimeters. Any of these is there, this patient needs chest drain. In here, we would not think about aspiration unless the rim of air is less than 2 centimeters. Patient does not have shortness of breath, age less than 50. In that case, if the patient having a rim of air 1 to 2 centimeters, you can go for aspiration. So just think about it that if the pneumothorax is large, patient having symptoms, usually you would go for chest drain in this case. Now that you know the management of pneumothorax, let's do this case, 15% pneumothorax in a young person with asthma. Use salbutamol when has upper respiratory tract infection. Saturation 95, what to do? Aspiration, chest X-ray after 24 hours, chest drain, oxygen, admit and observe. First of all, is it a primary or secondary? Secondary, very good, Dr. Naila. So because this patient having asthma, now look for is it a small or large? 15%, it's a marginal. We would think it as a large pneumothorax. So large pneumothorax, what is the treatment? Chest drain. So secondary pneumothorax, if it is large, we go for chest drain. Now exactly same question, but this patient does not have asthma. So 15% pneumothorax in a young person without any underlying lung condition. Saturation is 95. What will you do? Now, let's say this is a large pneumothorax because it's marginal, right? And patient does not have that much symptom. This patient does not have symptoms, so we will not go for aspiration. Aspiration is mainly for who has symptom. So aspiration is gone, chest X-ray gone. Now remember one thing, oxygen is usually, this patient will fall under this line, large but minimal symptom. If a patient have saturation of 95%, usually you don't need to give oxygen. That's not the indication of giving oxygen, right? So then you choose the next available option, which is admit and observe. Okay, so see the trickiness in the question. It's so much tricky for someone who does not understand the question. If this patient's saturation was 94, you could choose oxygen. So it depends on the whole knowledge of this discussion. You have to think a lot to come to an answer in these cases. That's why this carries a lot of mark in the exam. All right, so we have just few more questions to discuss for tonight. Maybe another 2 questions and then we can wrap it up. So 30 weeks pregnant lady presents to the ED with acute shortness of breath and chest pain started this morning. No fever, cough or hemoptysis. Blood pressure is stable, pulse rate is high, history of recent travel, normal chest X-ray. What is the next step? CTPA, VQ scan, ECG, CT scan, reassurance. What is the diagnosis? Pregnant patient having shortness of breath and chest pain, acute one, and having a history of travel, that's pulmonary embolism. And pulmonary embolism, the most common sign is tachycardia. If you think that this patient having pulmonary embolism, you don't do a ECG, you don't reassure, you don't think about anything else but to go for either CTPA or VQ scan. Every time we will choose CTPA except for a pregnant patient. For a pregnant patient, VQ scan will be the best choice of action. All right. Now, another important thing is, if in this question, there was an option of Doppler or duplex ultrasound of the lower leg, what would you do? Would you do the Doppler duplex as a next step, or would you do a VQ scan? Patient having a travel history. If patient have a travel history, most likely, where is the clot? Or from where the clot came into the lung? Obviously, this patient has got the P from a DVT, right? This patient is pregnant. If we can somehow, if we can just not do the VQ or CTPA, because both of them will cause some side effect, either to the baby or either to the mother. If we can somehow not do the CTPA or VQ, but rather we can understand this patient has got a clot, we would rather do that. Obviously not a D-dimer, because D-dimer will be non-specific in a pregnant patient. Now let's have a look. If imaging is required, this should be performed as soon as possible and urgently. Chest X-ray remains useful in determining alternative diagnosis, but we don't do chest X-ray if we are sure that this is a PE most likely. Definitive diagnosis will require CTPA or VQ scanning. CTPA is most commonly used, but VQ scan should be considered in pregnancy. why we are choosing this VQS scan in pregnancy? The radiation dose to the breast is much higher with CTPA than with VQS scan. But CTPA has a significantly higher maternal risk. Radiation risk to the fetus is low. Patients who are pregnant are generally younger, have fewer comorbidities than non-pregnant patients. VQS scanning, especially in the presence of a normal chest X-ray, is a more reliable test in pregnancy. Okay. Let me see if I can show you one of the important things that I wanted to just discuss. We will discuss in our class about the Wales criteria Park rule for choosing the appropriate investigation. Okay, it's not in here. There was one of the good guidelines from where I am talking. Now, let's have a look. So you guys know that this one will be a VQS scan, obviously, because in here you have got history of travel only, but no features of DVT. So yes, we can choose VQS scan, but have a look to the next question. 30 weeks pregnant, presents to the ED with acute shortness of breath and chest pain this morning. No fever, cough, pneumothorax, everything is normal. There is right calf redness, swelling, and tenderness. History of travel recently. Normal chest X-ray, next step. Now, what do you think you should do in this case? CTPA, VQS scan, ECG, Doppler ultrasound, and ABI. This is what I was talking about. If you can find out that if a patient having features of DVT, then you don't need VQS scan to confirm pulmonary embolism in this patient. If you do a Doppler duplex ultrasound of the vein and you get DVT positive, this patient does not need VQS scan or CTPA to confirm PE. Because this patient already got the symptoms and sign of PE. And you have already diagnosed this patient having a deep vein thrombosis. So that's one of the very, very important thing to understand, that if you get a feature of DVT in your stem, not only just a travel history, it has to be in the question that patient having cough pain, tenderness, redness, or swelling, then you can do a Doppler ultrasound of the vein, and that will be your best or most appropriate option also. So the initial option is that, best option is also that. You don't need VQS scan at that time. Okay. So in this question, your answer will be Doppler ultrasound of veins. Very, very tricky, guys. If you don't understand question, see that this is what I was talking about initially. I just added a single line and the answer is totally different. Okay. And if you just memorize the previous question from a Q bank, you would choose VQS scan and then you would ask, how come I failed? I did all the important things, but why I'm failing? That's the reason. Now, CTPA is not contraindicated for any renal issues. CTPA is mainly we try to avoid because of the risk of radiation, because CT scan gives more radiation risk than VQS scan. All right. And the risk of having a breast cancer after a CT scan, especially a CTPA, is very high in a younger population like this. So I was saying that if you get a patient, like a pregnant patient, having features of pulmonary embolism, but in the question you have also found that patient has features of deep vein thrombosis, you don't need to do VQS scan or CTPA to confirm PE. You just do a Doppler ultrasound of the veins, and if that's come back as a positive one, that's your diagnosis. This patient having DVT, you just treat the patient as it is. Because patient having DVT, if you confirm it, and now patient having chest pain, shortness of breath, tachycardia, that patient obviously got PE. You don't need to even bother with doing a VQA scan or CTPA at that time. Yeah, it's not for pregnant patient, Dr. Sidra. It's mainly for CTPA will be contraindicated in anyone having a chronic kidney disease. So someone having a stage 3, 4, 5 CKD, yes, then you can't do CTPA. And also, we don't do VQA scan unless we can find out patient's chest X-ray is normal. So normally, because if a patient has already some previous condition related with their lungs, like asthma, COPD, VQA scan will not be able to give you the appropriate finding. So to do VQA scan, you need a normal chest X-ray. So that's why we have already given normal chest X-ray next step. All right, I'm not going into any more questions for tonight. I think that's enough for you. So that was our just the initial tips and tricks for your AMC MCQ. A lot of questions we will discuss throughout the course, and you will understand almost everything. It will not be like this in 5 months' time. Okay, in 5 months' time, you will be like a pro. And you guys know that we have this new 5 months course, which is starting from 6th of February. And from 6th of February, for the next 2 weeks, there will be free session, just like how we are doing now. You will be able to come on Facebook and Zoom using the same Zoom ID and password. And we will discuss the cardiology. We'll solve some questions in terms of cardiology. And also one of our other doctor who will take some of your question solvation class, she will also take a question solvation discussion with you at the end of the 2-week session. So we will off it in your Facebook group. Keep an eye on it and join the free sessions. Just by joining the free session, you will get to know our approach. Always remember one thing, guys, that when you join a course, you should expect a lot from them. You are not wasting your money on something which is like which they're using for a long, long time. It should be updated every month. And we provide you the updated question solvation every month with weekly question solvations. You get your theory knowledge, everything will be updated version. And that's very important. Not only that, you also need to understand that if you enroll anywhere in a course who is not actually showing how they're taking the classes, just one class does not define a course. Or I would not even say just a 2 class will never ever show you that how a course is actually works. So if you're going into any course, ask them to give you 2 weeks free session at least so that you know them. Otherwise that anyone can take a very good class for 1 or 2 times, and then eventually for the next 3-4 months, you will just hit your head with a brick. So always make sure you get that, because that's a hard earning money that you're giving to someone, and you expect those things should happen. And in this 2 weeks free session, you can also get to know us. You don't need to enroll at this time. If you enroll and you want to get a refund after 2 weeks, that's also possible. Okay, so this 2 weeks free session is completely refundable. You can enroll yourself, or you can wait until the 2 week session is over, and then you can enroll. Whatever works for you works for us as well. All right, so join our 2 week session. See that if this is something which you are after, and if that fulfills your expectation, then you can join us. Okay, Now, one of the other thing is that if you guys have any question about the course, feel free to ask me in here. And if you don't have any question, that's also fine. I'm going to show you our course detail again. I know that some of you were there in our previous free session, but maybe some of you were not. So for you, this is the video that will give you an idea about the course in the next 5 months. So go through that. And if you still have any question, feel free to contact us at any time. So there's the video. All right, guys. So thank you so much for watching the video. I hope that explains the full course detail. If you guys have any question, you can ask me here, or also you can ask me in the next free session. Yeah, the recordings are always available for the first 2-week session and also these review sessions. All the recordings are uploaded in your YouTube. So if you, and we usually post it in the First Aid AMC MCQ group. So if you just, sometimes there is a lot of posts at this time, you can miss it. So if you just go to the search option of that group and write recording, you should be able to get all the recording in that way. All right, guys. So I hope you guys enjoyed the session today, and look for the next few week session, and then we will again we'll come back in 1 week time. Okay, so we'll be starting from 6th of February. Thank you all. Have a good night. Bye.